First I didn't know shit. Second I knew a little more, not much. But second stroke patient I ever had, his name was Jim. Jim could ambulate. Okay, he had some faults, but he could walk. So Jim was actually in the skill part, right? He wasn't working to attain and maintain anti-gravity static standing stability. He wasn't weight shifting stability. He was actually in the skill of walking. So he was pretty high level, but while he was walking, he had a foot drop. What's foot drop? Yeah. So to be more specific, he had decreased dorsiflexion. At which point in the gait pattern is that? The swing phase. Look at that. So you had decreased dorsiflexion at swing. So that's obviously with ambulation. So in your head, you're thinking to yourself, is that normal or not?
No.
Of course it isn't. So what's your next question?
How do you fix it?
Before that,
Why?
thank you, it's written up there, right? We need to know why he has decreased dorsiflexion at swing. Now the answer might seem easy, but give me 5 reasons why that patient, Jim, might not have dorsiflexion at swing.
The motor unit in his head.
Oh, whoa, easy, big fella. Slow down. Too complicated. Weakness. All right. So, of which muscle, by the way? Anterior tib. So, weak anterior tib. Could we assess that?
Yep.
How?
Energy.
Okay. Give me another reason why your patient, or Jim, it's our patient now, we're going to work with him, had a foot drop or had decreased dorsiflexion at swing.
He lost awareness of what it is.
So could be proprio or kinesthetic awareness. It could be a sensory issue. That's great, man. Maybe his strength is awesome, but he doesn't have the sensory input. Can we test sensation and proprioceptive input? Yeah, we did that, positional stuff, and Josh showed you all those tests. So yeah, we could assess that. All right, give me some other reasons.
Nerve.
That's more the diagnostic reason. I just want the impairments. Weakness, sensory, what else? Nothing?
He doesn't have any problems with it.
That'd be the weakness. Nice try.
Pain.
Pain. Yeah, maybe he hurts. Maybe that's why he's not dorsiflexing. Can we assess pain?
Yeah.
Of course we can. All right. What about tone? Hypertonicity, spasticity. Remember that little kid in the video that we were just watching? What was wrong with his feet?
Plantar flexion.
He was stuck in plantar flexion because of tone to which muscles? Gastric soleus. So maybe he has spastic gastric soleus. Right, that would cause his foot to be in plantar flexion, which would decrease swing. We could do a few more things. I'll just kind of give it to you. But remember in muscular, we talked about the talus needs to move on the distal tib fib. If you don't, you're not going to have dorsiflexion. So it could be a joint mobility issue. We can assess all these things. So that's all I did is I saw a guy walk. I'm like, that's not normal, foot drop. Why? Okay, let me go through all the possible reasons. I'm going to assess them. So with our patient right now, what do you think the answer was for why?
All of it.
No. No, I ruled, it was actually beautiful. I ruled most stuff out. So I looked at his joint mobility, that wasn't an issue.
I'm gonna go with weak.
He was hypotonic, so spasticity wasn't an issue.
Then what's
He had no complaints of pain, other than me. I shouldn't say it's a pain in the ass. Sensory was actually a little off. He did have some proprioceptive kinesthetic awareness stuff, but that wasn't the main reason. The main reason was this right here. He had a weak anterior tib. And specifically, he was 0 out of 5, because I MNT'd him. So with 0 out of 5, what's my job? What do I got to try and do? Mobility, which by definition is the initiation of movement. So my job was to work with that one particular part of his body to initiate movement. So even though he was working in skill, as far as those 4 stages, his ankle wasn't. His ankle was still in the mobility stage, initiation of movement. In a kid, how does a kid initiate movement? Mainly when they're born. What are the first movements?
Primal instinct.
What's that?
An instinct.
Reflexive, yeah. There you go. So the initiation of movement in kids is reflexive. So my job with Jim is to try and get some reflexive anterior tib contraction, hoping that his brain feels that contraction and starts to make connections to facilitate voluntary control. So when we're working in the stage of mobility, we're trying to initiate movement where there is none.
And this is an adult, you said?
Yeah, this is an adult, but again, the reason we talk about pediatrics is because it helps you understand intervention for adults. So in a kid, when they initiate movement, mobility, it's all reflexive based.
Now, how do you get to be at an adult, a 0?
Okay, patient has stroke,
Yeah.
Neurons
okay,
died.
yeah, sure. Yeah.
so the neurons that told his foot what to do, not working anymore, okay? But there's an area around that it's called the penumbra. We'll talk about that with stroke. But that area is kind of like, all right, tell me what to do. I want to help, but I don't know how. So we try and facilitate reflexive contractions, and all of a sudden, maybe the parietal lobe kind of feels it, and it's like, oh, hey, I feel something going on down there. And it starts talking to some frontal lobe neurons, and they start having a conversation. And next thing you know, maybe the frontal lobe, the parts that didn't die from the stroke, can kick in and help. That's what you're hoping for. But our job as a clinician is trying to facilitate movement where there is none. In this particular case, the anterior tib. So the how to treat is what we're going to do right now. So let's just look at the slide, and then it's all on there.
Russ, good question.
Yeah.
Not to backtrack, but
Let's go ahead.
parietal tells the frontal what to do,
They talk back and forth.
but cerebellum controls it.
Yeah. So the frontal tells the muscle what to do. The muscle's like, okay, but it's kind of like giving the car keys to a teenager. It's like, yeah, here you go, but. Right. So the frontal lobe tells the muscle, and the muscle just wants to react and do, but the parietal lobe feels what it's doing. It's like, that's either too fast, too slow, that doesn't feel right, you should be over here. So it's trying to tell it, where it is and what it's doing in the cerebellum. It's like, yeah, I got that. Let me help control the movement. So yeah, it's all a conversation. That's actually a really great question. This neuro thing is not, it's easy and hard all at the same time.
Yeah, because I was studying it, it was kind of like the
It's-
parietal was doing some of the same things, or
It's just they're all working together. Again, they have their own jobs: frontal movement, parietal sensory, cerebellum coordination. You need all 3 of those things in order to have a nice movement. You need the voluntary, all right, flex your arm, okay. Without the parietal and the cerebellum, that's what happens. Like, that's useless, right? The parietal needs to feel, all right, now I know your elbow's there, and there, should be there, should be there, should be there. So it's telling the cerebellum, hey, make sure we control that. Slow it down, slow it down, slow it down, because we're almost there. Good, good. Now speed it up. Go, 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 go. Constant conversation. Frontal says, okay, I'll make that adjustment for you, so it gives less power or more power to the muscle. Frontal says, oh, you contract a little more, or contract a little less, we gotta slow down. Big conversation. Ask that question every class. I'm fine with that, because if you understand that, then you'll know how to treat. All right, so let's start treating. That's not a person. All right. So again, we're gonna start working right here, mobility, stability, control, mobility, skill. I'm gonna show you specific interventions for this, this, and this, but right now, we're gonna work on just this. Now, mobility, again, it's not the whole person, it's just a part of his body, which we've determined is the ankle. So, here are all of the strategies to facilitate movement where there is none. All right, you ready, B?
Yeah.
Let's get to work. Come on up. I'm gonna have you go supine, please. Kim, if you don't mind, you grab me in the hand, I'm not videotaping.
Okay,
I felt good about the first one.
okay. What am I grabbing, ice?
Would you mind grabbing me ice and a towel? That'd be great. And if you can go supine deep, I'm gonna need you. I hate to do this to you, but I can take one shoe off, take it right off. Don't mind? Come on, don't worry about it. No worries.
Damn, took the wrong seat.
Don't worry. I take multiple precautions, trust me. All right, you can go supine, you can relax. I'm gonna call you Jim just because it makes more sense to me if that was the patient's name. You? All right. So, first technique we're gonna show you is, and now your job is to do nothing, okay? Because you have 0 out of 5 in this anterior tip of yours, okay? So, and that's what I was working with. He had like, you know, say 3 out of 5 here, maybe 3 plus here. Do these have to be perfect before I go after this?
No.
No, of course not. I know we work proximal to distal, but I don't have to perfect proximal before going distal.
You need something there.
Well, absolutely. Listen, I'm not gonna spend my whole day right here. Can't do that, okay? You gotta work, prove the point. You gotta work proximal as well. You know, I gotta work trunk, I mean, I gotta work everything, but we're like a month post-stroke. I wanna go at this guy. I wanna take advantage of that, part of the brain that can start making connections and maybe get this anterior tib firing again. So the first way that we do that, though, is we're gonna show Jim what motion we're looking for, and that's called rhythmic initiation. That's the name of the skill. Rhythmic initiation is gonna be used on every patient you ever work with. I'll explain that later. But all it is listen, what we're gonna do is we're gonna take your toes, and we're gonna bring them to your knee. All right, that's sort of you always wanna give them a visual for them to think about. Like, I know you like to drive, so, you know, you take your foot off the gas, you bring the toes up this way. That's what we're trying to do. So give them some sort of salient visual for them to think about, because if they can think about the motion, they're more apt to connect to do it. Another thing I'll say is, listen, why don't we do it on this side first so you can see it? So you take the foot off the gas, pull it up as high as you can. You feel that muscle working? Okay, that's what we're trying for here. So you incorporate the other side too, because you're hoping for that sort of cross connection. So you try and visualize, you try and have them feel it on this side. You're doing everything you can to get this side to work. All right, we're gonna do this thing called rhythmic initiation. But basically all it is I'm gonna show you, so we do it together. You don't have anything, so just humor me, just try and relax. Again, try and take your foot off the gas, bring toe to knee, so we're gonna go up this way, and that's the motion I want. Okay, and then we're gonna go back down. So again, I want you to think about it as best you can. I want you to try and bring those toes up. Come on, bring them up, 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 up. Okay. Obviously nothing's gonna happen because he's 0 to 5 point up, 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 up. What I'm doing is I'm giving him the visual, and I'm giving him the verbal cues that I'm gonna use as we go. So every time I say up, I want his brain to think about this muscle working. So again, people, we'll show you on this side. So you can do this side. So try and pull the foot off the gas, up, 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 and back down. Come on. Pull it up, 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 up. All right, we'll do the same thing on this side. That's rhythmic initiation, is showing the movement passively, explaining the movement verbally, giving him mental imagery to see it, giving him a verbal cue to connect it. All right, so that's that. Pull it up, 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 up. That's rhythmic initiation. What you hope for is that all of a sudden it starts helping, and it goes from passive to what?
Active.
Active assistant.
Active
Come on, help,
assist.
help, 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 help.
Right.
To obviously active, to active resisted, but I'm not planning on getting there, but rhythmic initiation is placed under strategies to increase mobility because the first step of it is passive, all right? So on a boards test, your patient presents to you with 0 out of 5 hamstring strength. The most likely intervention that you are going to implement is rhythmic rotation, rhythmic stabilization, rhythmic initiation, rhythmic rebounding. Rhythmic initiation, because we know rhythmic rotation is for a spastic muscle. Didn't say anything about that. Rhythmic stabilization is gonna be to improve stability, that's next week. Rhythmic rebounding, I don't know what that is.
Why do we skip, I know Doug kept saying Easton, why do we skip that step?
Oh, we won't. Oh, we won't. We're gonna get into that.
Okay.
So this is the part of the game where they give you a bunch of tools, and you see which one works for the job at hand. They're all designed to do the same job. Just you're gonna like one of the tools better. He's gonna like one of the tools better. So we're gonna give you 8 of them today, one of which is Easton and biofeedback. All right. So rhythmic initiation is where we stop. All right, Jim. So now that you know what we want to do, what I'm gonna do is I'm gonna tap that muscle belly. Okay. So you can feel me tapping here, hopefully anyway. And I may have a mirror too, so we can see it as well. But listen, when I say up, 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 I'm gonna tap, 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 tap. So we're gonna try and put that all together. And your job is the same thing. Take your foot off the gas. So and up, 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 up. Okay. And up, 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 up. Anytime you want a muscle to do something, you tap it. Now, in his case, nothing's happening. But maybe somebody's like a 4 out of 5, and they're just not doing it quite like you want. Come on. Anytime you want a muscle to work, you tap it. So, we just did rhythmic initiation, that's up there. We did tapping, that's up there. And here's another thing you can do. It's called quick stretch. You guys heard of quick stretch before? At all? No?
Is there a stretch that's quick?
It's pretty much it, man.
Alright.
You know what a quick stretch is? You ever go to the doctor and then they do that?
Yeah.
That's a quick stretch. So
Yeah.
when they hit your patella tendon, what does it do to the patella tendon?
Reflex.
It bends it and stretches it. So that information of the deformation of the patella tendon goes to the spinal cord, and the spinal cord's like, crap, I'm worried about that patella tendon. I'm gonna contract the muscle and protect it. That's what a reflex is.
I thought that was.
So it stretches to contract.
It is a reflex test, but it's a reflex test based on a quick stretch to the tendon, which should elicit a response from the spinal cord to contract that muscle. So, I should have videotaped this class. It's better. It's always better. Of course, that's on video. Jim's gonna be devastated. So, if I quick stretch a tendon, that should cause a muscle to contract. So, what tendon should I try and quick stretch to get the anterior tib to contract? No. If I quick stretch the Achilles, it's gonna make the Achilles or the gastroc contract. So if you want the anterior tib to contract, you quick stretch the anterior tib, hoping that it feels the deformation and then kicks back. Okay? So we do the same thing. So this time, we're gonna tap, and I'm gonna move your foot like you want, but I'm also gonna give a little one of these. Okay, so you ready? So when I do that, after that, I'm gonna say up, 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 like we've been doing. Okay, so you ready? And up, 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 up. I'm still rhythmic initiating. I'm tapping. I'm quick stretching, and come on, pull up, 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 up. I'm putting things together. I'm trying to elicit a response. So all of a sudden, the anterior tib started. Every time I did it, it sort of started kicking back. First, is that good or bad? It's good. Is it voluntary? No. So why am I doing it then? If it's not voluntary, what do I care?
It just, the brain is
Making
realizing it's there, I guess.
Making connections. If say it contracts, even if it's an involuntary reflexive contraction, it contracts. The brain's like, whoa, what was that? I felt something down there. All of a sudden, it starts talking with some guys like, hey, remember that guy down there? Henry? I don't know. Remember he used to kind of take the foot off the gas for us, and all of a sudden you start making those synaptic connections. So in the stage of mobility, we're trying to get a muscle to reflexively contract so that the brain can maybe catch that and start voluntarily contracting. That's it. All right, so we got rhythmic initiation, we got tapping, we got quick stretch with rhythmic initiation. Another thing up there is called vibration. Fan off. Yeah, it's been called other things.
Nothing V hasn't used before.
All right, anyway.
Hey, you put me on the bus under the bus earlier. I had to get you.
All right, so
He does, right?
another thing you can use is vibration. You can use it a couple different ways. This is all in the book on, I think it's like 316 to 317, something like that. But anyway, the other way we do is listen to me. This time you're going to feel, it's just going to vibrate on the muscle. When you feel it, I want you to try and kick that muscle up. Same thing, I want you to try and, sorry, let me rephrase that. I want you to try and take your foot off the gas, like I've been saying every time. Don't change your cues or your description, that's dumb, sorry. So you ready? Okay. So when I swipe it up, come on in, up, 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 up. Good. Listen, these techniques, remember rhythmic rotation and neutral warmth, those were all techniques to put a kid to sleep. We were trying to inhibit spasticity, put it to sleep. This is all stuff to wake up a teenager. You think about it, when you wake up a teenager, it's like, come on, hey, get up. Hey, get up, get up. You know, it's, come on, go, let's go. You're quick stretching, you're tapping, you're rhythmically initiating. Come on, wake up, you're vibrating. These are all ways to wake that muscle up. So same thing, so when you feel it, foot off the gas, come on, up, 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 up. Good, and I'm still rhythmic initiating. I could even give a, come on in, pull up, pull up, pull up, pull up, give a quick stretch, rhythmic initiation, vibration. You can do one of these at a time, you can put them all together. All right, so that's that, that's vibration. So you can either swipe with vibration, or you can hold, I think it's 1 to 2 minutes to facilitate. Either one works. Does it feel good?
Yeah, it doesn't feel bad.
Okay, I'm doing it now. All right. Another thing is, and it's up there, is called quick ice. It's exactly what it sounds like. You swipe the muscle belly with ice. It's the same thing, so you're gonna feel this cold swipe. And the same thing, you feel that cold swipe, try and pull toes to knee, try and take the foot off the gas. You ready? And pull up, 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 up. Okay, and pull up, come on, pull, pull, pull. So you're just swiping quick ice on muscle belly. It's yet again another technique. All right, that's it, Knievel. And then,
Russ, when you're going back between initiation and quick stretch, you didn't move your hand. Is that like a rule, like to not move your hand at all?
not necessarily, just, it's the best way to, can I have another towel? I'm sorry. It's just, so I push down this way and then I assist that way.
Okay.
It gets tricky, so I'm gonna have you practice with the hamstrings. It gets tricky when you start trying to do all these at the same time, thank you, like, you know, quick stretches and tapping, and it's like walking and chewing gum, so, yeah. All right. All right, so that's quick ice, that one's up there. Let's see, what else we got up there? It's not up there, so let's just, oh, E-stim, we haven't even talked about E-stim. E-stim is, you know, so what did Deb say about E-stimming a 0 out of 5? What do you use? What
Because
kind?
of the muscle size, but it's a progression right back.
Okay, so, yeah, so listen, I'm not an E-stim guy. When I do E-stim for 0 out of 5, I look in the book and it's got the settings or whatever.
Just like biphasic or
Yeah,
Yeah, right. And I just, again, the machines we have, basically, you just, you know, say what you want, like, you know, tells you the program and stuff, but, yeah, you can try E-stim. And again, you're hoping for E-stim isn't voluntary, but you're hoping that the muscle contracts because of the impulse to the nerve and that the brain senses it. Same thing every time, guys, that's all we're looking for. So you can use E-stim. And then it gets a little bit deeper, so like then you say specific muscles like the anterior tib. One way to facilitate dorsiflexion, and I'm not doing this one, is you put your fingers between all their toes, You abduct their toes, and then you pull a little traction, and once you do that with the traction, it's been shown to facilitate dorsiflexion.
I'm not about that.
Yeah. I don't deal with toe cheese.
There's a picture of it in the book on page 316. So it'd be the same thing though, it'd be like, come on, and pull up, 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 up. So you're still doing the tapping or the rhythmic initiation or the quick stretching with the fingers between the toes. Okay, ready, and pull up, 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 up. So you're putting all these things together. Maybe you're doing that with E-stim on. Again, I'm just giving you a bunch of ideas to get a muscle to do its job. That's like 6 or 7 or 8 so far. So with the actual patient, I was doing this and doing this and doing this, and I wasn't getting much response, and I was getting frustrated. So then I said, I'm gonna take it a step further, and I started researching and reading articles. Now, it was a little bit tougher when this was going back probably 15 years. It wasn't as readily available, but I found this one thing in this one book that said if you swipe ice between the 4th and 5th toe, that might elicit a dorsiflexion response. So I said, okay. So I quick ice between the 4th and 5th toe, and all of a sudden, my finger was on it, and I felt it. I felt it again. I felt it again. We kept doing it, but then I went, let's get the E-stim back in there. Let's double down. Let's tap more. Let's quick stretch more. So I was now getting excited because I got something. And then we kept doing it, and then sooner or later it went from reflexive. So all of a sudden I said, all right, with that rhythmic initiation, he helped me. Second he helped me, I knew we had it. And then we progressed. I think he got as far as like a 3-, but it allowed him to not use an AFO. So that was one of the good outcomes. And out of home runs. Hopefully that gives you some ideas on how to facilitate this. What I'd like you to do is break up to a couple groups, take the hamstrings. Pretend the hamstrings is a 0 out of 5. Do all of these techniques: rhythmic initiation with the right verbal cues, tapping, quick stretch, vibration, quick ice, E-stim. Just think about where you put the pad placements and see if you can do it. All right? Let's start with that, and I'm going to give you some scenarios.